All right, welcome back. Thank you for staying with us. The set has changed. That means that the topic is also changing. It's time for To The Point. And tonight we are talking about endometriosis. This is a topic that has had the country talking for the past maybe a few days or 1 week. And this is after we lost a media star, that is Jambi Koikai. And in honor of Jambi Koikai, we want to understand what really is endometriosis. Our guests are already in studio. Just right next to me, we have Dr. Paul Koigi. Dr. Paul is a special obstetrician that is also he deals with matters fertility and is also a gynecologist. Next to him is Lucy Mweni. Lucy is an advocate, an endometriosis advocate. We have Dr. Charles Muteshi just next to Lucy. Dr. Charles is an endometriosis specialist. And we have Elsie Wandera. Now, Elsie is the founder of the Endometriosis Foundation of Kenya. That is quite interesting. And we want to just to get to know what they do at the foundation. And remember, Elsie, I didn't say this, but Elsie is also a survivor of endometriosis. If she can survive, then we want to know how did she get here and how was her survival journey like. Now, let's just get started with understanding what endometriosis really is. Now, according to the World Health Organization, that is WHO, this is a disease in which tissues similar to the lining of the uterus grows outside the uterus. It can cause severe pain in the pelvis and make it harder to get pregnant. I don't know if the doctors in studio tonight will agree with this. Let's just start with you, Dr. Paul.
Thank you very much for having me over this evening. And I think this definition does reasonably summarize the concept of endometriosis, because it basically allows for us to deduce that the lining of the uterus is capable of spreading from being where it's supposed to be and spread to technically almost anywhere throughout the body.
Dr. Charles, do you agree?
To an extent, yes. I'm not sure whether it's very lay-friendly, because if you tell a lay person, tissue similar to the lining of the womb or the uterus, I think it becomes a little bit difficult to conceptualize. If you say the cells that look like menstrual flow lying elsewhere, perhaps it could come closer to their imagination.
All right, Elsie, when you were first told that you had endometriosis, how was it described to you?
I think for me that was like a very wow moment, because I remember the doctor describing it to me as my uterus was growing inside out. That was the easiest way he could help me understand, because it was such a mouthful. There were a lot of words he was using and I'd never heard of before. And so I felt like, I just told him, please just make it simple for me to understand. And so I went around for a very long time telling people that my uterus was growing inside out. So it was the simplest description. And I understand what he was trying to help me understand, which is those cells, were of course outside of my uterus and how it was manifesting, and stuff like that. So, that was at the age of 26. And I think I had suffered with that pain, not knowing what it was, for about 13 years. So it took a long time to diagnose for me to actually know what I was suffering from.
All right, Lucy, before I bring you in, let me just get an opinion. If you are saying, from the doctors, of course, and all of you in studio tonight, if you are saying that there's no a layman's explanation to what endometriosis really is, then let's say we are dealing with a teenager. How do you tell them that your uterus, rather, is just growing outside your uterine walls? How do you make them understand?
I think that's a very interesting challenge, because number one, you're dealing with children who are, whether it's a teenager or somebody who is a young adult, you're dealing with somebody who has what may be the bare minimum in terms of understanding some degree of reproduction biology. For those who are fortunate enough to have done a few of the more advanced topics in biology, those ones will be able to understand that the woman has a uterus, and these are the parts inside the woman, and these are the parts inside the man. And for her as a woman, there can be a problem with the lining of the uterus, and that is what is actually raising that as an issue for her. And typically, one of the things that may make them be able to relate with it, and probably the most likely symptom that will make them come in to look for care, is that they'll tend to have periods that are so bad that for the maybe 3 or 4 or 5, and for some maybe even a week, and for the extreme ones even up to 10 days a month, they're stuck on bed rest, taking painkillers, and some of them end up moving from painkillers that you have to swallow and moving from the basic painkillers to stronger painkillers, and reaching a point that they need painkillers that are strong enough to require to be injected in order to try and manage the pain. And for the ones for whom the disease may have become even more severe, it may have progressed to the point that they end up having pain even outside of their menstrual periods.
All right. Now, Lucy, you are an endometriosis advocate. How did you get yourself to this point where you now have to, I understand on our side chat you mentioned that you do not have endometriosis yourself, but you are advocating for those that have. How did you get yourself here?
Well, Odida, this came when I was, let's say, in high school. I used to experience very painful cramps that would even stress my parents and even people that were around me. So let's say I came across the word endometriosis when I was still trying to figure out what was wrong with me. And that's when I got to understand what it was. And I imagined so many people that are going through it, not knowing what it is exactly. I like to call it like I had told my fellow panelists. I like to call it a cancer that is killing women slowly. So I decided that I will be talking about it, even from high school, even before I became a model, and got a platform where I can properly communicate about it. So yeah, that's how I come about it. And to answer the question that you had asked previously, you know, you can even meet a grandmother that is taking care of young girls, and they do not understand English.
Right.
So what I'd like, I don't know if doctors will agree with me or Elsie, I'd like to tell them the inner layer of your mouth. You can imagine that growing from outside of your mouth. That's how I basically explain what it is in layman's language.
That's quite interesting. And Lucy has a crown on her head. I don't know if we should also just talk a little about it. Tell us about your crown before we continue.
Okay, this is Face of Africa Fashion Week. Maybe I just say it like Face of Africa, but it's Face of Africa Fashion Week. It's something that was formalized by Delight School of Fashion. It's literally a show that happens, and now they were looking for a face to represent it. And to be a face, you must have something to talk about.
An advocacy.
So, yes. So I already had endometriosis, so I came about it. But basically, it's also a platform that appreciates African culture and African fashion. So in the middle of it all, I also talk about endometriosis.
All right.
Yes.
From what I'm getting is that endometriosis is not talked much about. Elsie, why do you think this is the case?
I think it's one, pain has been normalized for a long time. And from a very young age, you know, like girls and even just women, I don't think there are spaces where we talk enough about the disorders that come with menstruation. I think even just menstruation alone is a very difficult conversation and topic. You know, there's a lot of stigma around it. You know, there's like almost like shame associated with menstruation. And, you know, for a long time, you know, women and girls have been expected and have been socialized like to endure and almost stoically carry this pain without complaining, you know. So while it is known that, yes, you know, there are women who are suffering painful periods, I think just just the spaces and the spaces to advance the conversation, to just make sure that it is safe for people to actually come to see gynecologists, I think should become normal practice. I think we were talking about it just, before we came on the show, that, even culturally, for me to actually say that I'm actually going to see a gynecologist, has, linkages to, sexual activity. So are you going to see a gynecologist because you're sexually active? So imagine, the delay, even in terms of diagnosing endometriosis is contributed because, one, I don't even feel like it is right for me to actually go and see a gynecologist. So I think there are a lot of barriers just to address it, and so that we just make sure that girls can first that we believe them when they say that they're actually in pain. We believe that there is an issue. Secondly, is also making sure that we normalize, just going to see gynecologists, that it's actually good practice for us as women to make sure that we're keeping up with our reproductive health in general. I think for me, that's how I would look at it.
Dr. Charles, you are an endometriosis specialist. Now, to get yourself at such a position, maybe someone is watching us today and doesn't even know that there is actually a doctor who only specializes in endometriosis. Why is this topic not given the much keenness that it deserves?
There are multiple factors, and I think if you look at the general, health ecosystem, we talk about other things that everybody thinks from a population health. They cause what is very obvious damage. For example, maternal death. To gynecologists and obstetricians, they are all worried about women who are probably dying. We all talk about child mortality. We talk about malaria, tuberculosis, and everything else that is very visible. And then there is this area that is least understood, and it doesn't carry that much weight, but we know it causes a lot of suffering. So for a general gynecologist, they will be in their training focused on what has a big impact on the population. But then it requires subspecialist training to understand endometriosis more. And of course, we know a lot more people suffer with endometriosis. So I think we have to change this kind of thinking.
All right, now, Dr. Paul, when we have someone, just a teenager maybe, coming to you for this checkup, and how do you receive them? Now, when you want to break it down to them that they have endometriosis, like Elsie is saying, that people usually don't want to go for these visits, maybe because of how it has been perceived. Let's say maybe if you're sexually active. So how do you tell them that this is actually important for them?
Okay. I think that's a very interesting question to address, because one of the things that if I was in a space of addressing a client, a teenage client who has hopefully come with the parents, I think the first thing I would try to do is, first of all, break the stigma and congratulate the parents and the child for coming in. Because reaching the point of accepting to look for help is actually usually because of desperation. And accepting that this young lady needs help, accepting to come and seek the help, is the first step in the treatment journey. So by that time, she's likely to also have bridged several other steps in terms of having passed through several other doctors who may have given her different aspects of information to try and justify what the problem may be. So if we've performed the relevant investigations and we feel that endometriosis is the likely culprit being responsible for the symptoms, then what I would do would be to, if she'd be comfortable having this discussion with her parents present, is sit her and the parents down and explain to them what the parts of the uterus are, because usually we will need at least at the bare minimum of an ultrasound, and explain the portions of the uterus and explain what is happening that is interfering with her ability to have her menses normally, and explain that what is supposed to come out as the menstrual period, instead of coming out, is now spreading inside the body and going to places that it should not go. And because of that, it's what may be responsible for painful menses. It may also be responsible for problems like having pain when she's trying to pass stool. It can also be, depending on how far it goes, if it goes to the front, it can also cause pain when passing urine. And it can cause pain that is there all the time. So at least when we start with it from that perspective, then I think it makes the child stop looking like she's been malingering all that time, because even teachers in school and fellow students keep on thinking that this is something inside this girl's head. And there are others who actually even give it a funny name. They call it Hapanapale syndrome. That today it is a pain here, a pain there, a pain somewhere else, instead of saying, this girl is suffering. She can't perform the way she would wish to perform. She's going to have trouble realizing her dreams in life, and let's put her through the works from the medical perspective and see what we can do to help her.
All right, we are still exhausting on the topic endometriosis, what it really means, and I believe our viewer can just see for themselves that we are really just trying to find a deeper meaning into understanding more about endometriosis. Now, Lucy says she was diagnosed by cyst. Tell us about that.
Ovarian cyst, what they like to tell me is sacs growing on my ovaries, which do not really have a cure, but manageable. I still have them to date, and I still have like very painful period cramps. But I can say that their pain has really changed over the years, and I think it's the constant attention to managing it, as per what gynecologists say. Before I used to go to just doctors, like the outpatient doctors, and what they'd say is my pain is just normal and that they will disappear once I give birth. So at some point I actually considered giving birth so that they can disappear in high school, Form 1, Form 2. But getting someone to tell me to put a name to my suffering was really a life-changing moment, and I was happy about it. So if we can get more ladies out here suffering without knowing what they're suffering from, just to go and find out what they're suffering from to the right people, that would be amazing.
All right.
Yeah.
Now, when we get also doctors saying that's just pain that will go away, it's quite interesting. And we are coming back to just understand why doctors will tell a patient in pain something like that. Okay, let's take this break.
Kila kiongozi ana hadithi yake ya kipekee.
Wazazi wangu walikuwa bit strict kwa sababu mamangu mwenyewe, mimi kutoka kuzaliwa sijailala nje.
The white small one, huyo ana sniff gunpowder na risasi na bomb. Alafu huyo mwingine ni Ridgeback ana sniff Simba.
Even the employees knows that, so when in the boardroom is the chairman, the CEO, and the rest of.
At what point are you a wife?
The minute you get to that inside that door, you become now the wife.
Na kila maamuzi wanayoyafanya hufichua mengi kuhusu utu wao na uongozi wao.
We see God blessing us, and we now realize the power of giving also has to be rewarded back.
Kupitia kipindi Mfahamu Kiongozi, tunakuletea mahojiano ya kusisimua na uchambuzi wa kina kuhusu viongozi wetu.
Pick your core business as the bigger stones. Put them in your diary first. Give priority the bigger things.
Usikose kila Alhamis saa 1:30 jioni.
In a world where challenges are as common as opportunities, there are those who dare to defy the odds. They are the entrepreneurs. Entrepreneurship isn't just about starting a business, it's about embracing uncertainty, pushing boundaries, and turning dreams into reality.
Hata ambao ni pesa ya kusave, wallahi. Ambao mwaka ni pesa nyingi sana.
As long as you're earning something, there's always that opportunity to save. And you start with where you are.
The way we run the business is in a very unforgiving way, where every team member has to bring out their best.
So, to all the dreamers, innovators, and risk takers out there, remember, being an entrepreneur isn't just a job, it's a way of life. Join the journey. Become an entrepreneur. The Grind, Mondays at 7:30 p.m. Grind, Mondays at 7:30 p.m.
All right, welcome back. You are watching To The Point, and the conversation tonight is this: endometriosis. We have just exhausted what this really means. And before we went on that very short break, Lucy was telling us how doctors sometimes tell their patients that this is just a mere pain that will go away. And before we get into our next slide, let me just hear it from our doctors. This is just a mere pain that will go away. What will the doctor tell a patient in pain that?
I think that's a difficult question to answer because I don't remember ever telling a patient that your pain will just go away. And usually the way our bodies are designed, when somebody is in pain, it's actually a warning signal. It's a red light that there is a problem. So ideally, it should be something that should be investigated. However, that said, there is probably maybe one type of pain that may occur in a lady's menstrual cycle. That would be somewhere around the middle, around the time of ovulation. There is a certain pain of ovulation that may occur when the egg is released, because when the egg is being released from the cyst in the ovary, it is being released and it stretches the lining of the ovary. It's called a capsule. So it stretches the capsule of the ovary, and that can cause some pain before it is released. That usually just comes, pops, and goes. But I think other than that, it's very difficult to find pain that can just be so easily written off.
And let me hear it from an endometriosis specialist.
Yeah.
This is just a mere pain that will go away.
Partly because I think it's, I would like to apologize first of all on behalf of the doctors, because we wouldn't want to dismiss pain. It's important always to go deep into understanding menstruation, and we don't have time to go into all that detail, but menstruation is not really bleeding. It's shredding the lining of the womb and expelling it, and the body has a process to do that, and it's very painful by its nature, but the amount of pain varies from person to person. So sometimes it could just be mild discomfort and it doesn't bother you, but if it bothers you to the point that it stops you from doing whatever you normally would do, and then that is not pain that can be ignored.
All right, thank you so much, ladies and gentlemen, for that. Now, let's take a look at the risk factors of endometriosis. And this is according to Dr. Megan Wasson of the Mayo Clinic. And just at the top, we have infertility. And what Dr. Wasson says is that women who have never given birth might be at risk of having endometriosis. We have early menstruation, late menopause, short menstrual cycles. We have heavy menstrual periods, high levels of estrogen, low body mass index, alcohol consumption, that is quite interesting, alcohol consumption. And we have also family history. I would just love to start with Elsie. How were you told? Did you also have these symptoms that you were made to understand that you can never bear kids?
Yeah, I think when I was first diagnosed, I think that was one of the difficult things to just understand and for me to grasp at the time, because I was 26, you know. And, you know, the gynecologist at that time was telling me that, yes, I will have challenges, I will face challenges. And so his immediate recommendation was, one, I would, of course, be going through some treatment for like 3 months, you know, where they suppress the production of estrogen. For like 3 months, I don't have periods, and I think it was 3 to 6 months. But then he immediately told me, you know, think about getting pregnant now. And I was just like, yeah, let's make it a project. So I was 26 thinking about having a baby because I thought, you know, I was going to miss out on that opportunity. And I mean, I don't like to dwell on it too much, but yeah, it's a fact. I have had 4 surgeries, you know, to manage the endometriosis, and I lost both my ovaries, so I cannot conceive, you know, just naturally. I would need to be assisted if I needed to. And I am now going through hormone replacement therapy, and part of the diagnosis is that I am in early stages of menopause, which I shouldn't be. So there are a lot of things, you know, and for me, I don't think, I used to believe that I would be able to have children, but it was just, it was difficult. It was proving difficult. I think when I was, I think early 30s, my AMH levels were already, you know, like beginning to show like they were very, what's it called, like low levels. And that, of course, was going to impact my fertility journey. And I remember having, you know, conversations with my gynecologist, you know, just openly, just where before surgery they would say, you know, please note that this is something that you're at risk. And, you know, because the more they kept digging around the ovaries, the more you're eating into that reserve that is there. But I mean, not to scare anyone. It doesn't mean that you cannot have you know, children in the future. I think the most important thing to make sure women and girls are aware of is have the conversation with your doctor, and so that, you know, you're presented with your options of, say, for example, preserving your eggs, you know, or making sure that if you want to prioritize having pregnant, I mean, like getting the babies early, do it. I mean, like, and let those options be presented to you before you actually make the decision to have surgery. I think those, for me, I think those are the most important things I would encourage women and girls to know.
Lucy, how about you? Infertility, have you been told anything like that by your doctor?
I'd say that gladly not yet, and I hope it will never happen. Yeah, but I know it can happen because when you have sacs on your ovaries, sometimes you can even, sometimes the pain is so much. I remember one time telling my mom that I want to get everything out, everything that makes me a woman out, or everything that causes the pain out. So sometimes people might consider just having it all out because the pain is excruciating. The pain is so unbearable. So you better not have the kids if this is what's gonna happen. At the same time, you also don't know if you get pregnant, if you're going to manage it, because you can have, you can lose the baby or have a life-threatening moment.
Pregnancy.
Yes. So I can say that I've not really been told so, and I hope not.
Interesting. Dr. Charles, what are the chances of one getting pregnant with endometriosis?
I think I would say that having a diagnosis of endometriosis is not equivalent to being unable to have children.
Correct.
And many ladies who have endometriosis actually get pregnant and are able to have children. Endometriosis, though, can be a risk for delayed conception for various reasons. So it's not very direct. But most women who may have endometriosis can have children, either naturally or sometimes with assistance. And not everybody who goes through assisted conception has endometriosis. There are many reasons why assisted conception may be indicated.
Interesting. So there's hope after all.
Yes.
Dr. Paul, you specialize in matters fertility. So tell us, what treatment have you found most effective for women with endo?
So the most effective treatment for endometriosis?
For infertility, sorry.
For infertility. I think the best treatment for infertility depends on the cause. Because for somebody who has a problem like endometriosis, for endo, the best possible thing is, as much as possible, get as much of what is in the abnormal space out, because when that endo is in that space, then it is also generating chemicals. It's generating chemicals, it's causing inflammation, it's causing tissues to stick in spaces where they're not supposed to and causing pain. And there's actually there's new upcoming research that says that there are certain chemicals which are being produced by that endo that actually directly interfere with the ability of a pregnancy to take. So as much as possible, try and get what you can get out in relation to that endo. And then in event that there are any other causes relating to difficulty in conceiving, address that. And for those who have very many risk factors, for instance, if the uterus has been completely messed up, then even offering her IVF may not necessarily be the right choice for her, because if the lining inside her uterus is not going to be welcoming to the pregnancy, then it may actually be better to offer her the opportunity to have someone else carry the pregnancy for her.
Correct.
And then she has the baby through that way.
All right. Now we also have an interesting one here, that is early menstruation. When someone starts their menses early enough, they're at risk of getting endometriosis. How and why is that, Dr. Charles?
I think the mere nature of endometriosis is a condition that presents itself with periods. So for girls who've had periods earlier, they are likely to be diagnosed with endometriosis than those who have their periods later. And it doesn't mean that if your periods come later, you won't have a diagnosis of endometriosis. And also, it doesn't mean that every lady who has very early periods will have endometriosis. We have looked at, associations. It's not really causes. So an association is not a cause. And when we link these two, it just means that we have observed this girl for much longer, and they are more likely to have symptoms linked to endometriosis that we observe than someone who has not had their periods. So it doesn't mean early periods cause endometriosis. So it's very important always to know that cause effect is different from association. So periods by themselves don't necessarily cause, but we know they are linked to endometriosis. Yeah.
Elsie, how early is early from your own point of view?
I think I'll talk about myself, of course. I started my periods when I was about 13 years old, and I started presenting my symptoms when I was 15, right? So I think that maybe is the early. Like for me, that was when I knew, like I was going through something abnormal, I was missing classes, I was unable to participate fully in, activities in school, and, I was like Dr. Koege says, is that, I had to get injections for painkillers because oral medication for me was not working. So, Charles is probably and Dr. Paul are the ones who can actually say like how early is early, because they're the ones who are treating those.
All right, Dr. Paul, how early is early?
All right. I think if we were to give an absolute benchmark, typically in our population, we have most girls clocking adolescence probably around the age of 11, 12. But we actually nowadays are finding that there are girls who are starting having their menses, some as early as 7 or 8, 9 is a little bit more common. So you can actually find, by the time you have a 7-year-old child who has barely stopped using diapers, barely been potty trained, and the next thing you know, voila, she needs pads. So that can actually be very early.
Right.
Yeah.
So anything under the age of 9, 10 would probably what we would consider as very early. Yes.
Probably we can also just touch on alcohol consumption. We are in a generation where alcohol has been normalized. So how do you deal with such, Doctor?
Alcohol is a very interesting drug. It's thought to be one of the most common drugs of addiction on the planet. And probably one of the things about alcohol is that alcohol doesn't just cause dysfunction to the brain in terms of causing you to stagger and get drunk and get high, but it does cause dysfunction in very many other organs. And if we are to take the primary organ that gets hardest hit first, and that would be the liver, and the liver is directly responsible for production of a lot of hormones and a lot of proteins that directly influence the ability to have your periods, the ability of your body to be able to produce the hormones, and the ability of the body to respond to the hormones. So alcohol does have a very significant bearing on that disease, as a disease process.
All right, Elsie, you were laughing when I was asking about alcohol consumption. Maybe you can tell us something that you have to say.
Well, yeah, and not, again, because we don't know still what causes endometriosis, right? But we know that, yes. I think one of the things as the foundation, and one of the things, that I guess I learn is every day, is that something may affect me differently than it affects another person, right? So even when you think about lifestyle, your lifestyle, and so we encourage just the endometriosis patients and warriors, as they are called, to just look after themselves as best as they know how to, right? And how their body, the way their body will respond, the way my body will respond, like for example, to coffee or to dairy products, is not the same way that, another patient will respond. So there are things that will aggravate the pain. For example, I know, and I've read that in discussions in the, in our support group, where someone actually decides, I'm not going to drink for the next 3 months, and they actually see a difference in their pain levels. There's no study to say that, like if you stop this, it's going to do this, right? So like what Charles was saying, we don't, cause and effect. Especially when it comes to endometriosis, we still don't know. We're still in the dark. So I think it's about listening to your body and how your body is responding to some of these products. But, so I know of, and the reason why I laugh is because lifestyle, convincing people to change their lifestyle, asking them to stop doing one thing and start another thing, is like a, I don't know, it's like a mountain. You're trying to push a mountain, you're trying to move a mountain from this point to that other point. And whereas you're imagining that this pain should actually drive a person to actually want to make drastic changes. But we know that endometriosis also largely is, part of the challenge is the mentally. So if you're not in that, like if you're not talking to yourself positively. If you're not feeling positively, if you're not feeling good about yourself, then it's very easy to find people, just depending on alcohol to feel good. So,
all right. Yeah. Before we run out of time, of course, you have mentioned, doctors, right here, that because of endometriosis is not known, and that is also according to the WHO. So maybe we can take a look at the management of endometriosis associated plan, and we have a surgical ablation, or maybe just excision of lesions. Is it lesions?
Lesions.
Lesions. Sorry about that. We also have hormonal treatments and non-hormonal treatments. Maybe you can tell us about this. The hormonal treatments, are they the similar ones to what we call in layman's term as a family plan, or
So yes, the short answer to your question is yes, that some of the hormonal treatments are actually within the scope of the family planning pills that we offer clients for family planning. And they carry value because they can actually help in terms of giving this young lady or older lady, depending on her age, the opportunity to have more regular menses. And depending on which hormones are present in the pills, then it might actually make her periods significantly lighter and therefore significantly help in relieving the symptoms.
Dr. Charles,
yes,
do we have any form of management that only applies to a particular stage that one is in?
I think we try to look at endometriosis as a disease whose management is not a one shoe fits all. So basically, what that means is it's individualized. And the reason why endometriosis is individualized, because we make a diagnosis of endometriosis in teenagers, we make a diagnosis in ladies in their 20s or 30s, and we make a diagnosis in ladies who are either going into menopause or even during menopause. So the kind of management will depend on the individual. And a young girl who is only maybe 13, 14, 15, doesn't need to go through very extensive operations and all manner of things, because organs are still developing, a lot still happening in their bodies. And just the toll of such an approach to treatment might be too much. So we tailor their treatment depending on their need. And then if you have fertility desires, perhaps in your late 20s, early 30s, into your 40s, and you have endometriosis, then we would say it is better to try and operate and remove the endometriosis. And we now know the gold standard of surgery for endometriosis is to remove the lesions, what we call excision. And it's quite delicate, but then once you remove that, you give them a very good chance that they are going to feel better. But more importantly, it's not a touch and go. A patient with endometriosis requires to be on what we call a life journey. So you map out a plan and say, you are here now, and 5, 10 years, you're going to be here. What are we going to be dealing with? It keeps evolving, so that kind of care changes over time.
All right, thank you so much for that. Now let's take a look, as we close, at the countries that have had menstrual policies, and we should be starting with Japan. Now, Japan introduced menstrual leave in 1947, that is allowing their women to take time off if they experience severe menstrual pain. All right, we have Indonesia, where women are entitled to 2 days of menstrual leave per month. South Korea, labor laws provides female employees with 1 day of menstrual leave each month. 1 day, but at least it's still something, yeah? We also have Taiwan, where it also allowed their women since 2002. We have Zambia. Zambia is the only African country that gives women a leave, and they've dubbed it as Mother's Day. That is quite interesting. And we have Spain that recently just joined the team, I guess last year, where they say that 3 days that is covered by the public social security system. Kenya. Let's just start with Elsie. Why can't we get to a level where we now have a menstrual policy that just gives women who are battling pain to stay home or just maybe see their doctors? And before you answer me, maybe I was having this conversation on social media, and I asked, what do people think when we, as women, we are given a law where we are allowed to be home when maybe going through periods? And somebody commented that women will miss out on opportunities. What's your take?
It is, that's a proven fact. A lot of the, let me not generalize it, but we know of women who are suffering with endometriosis. We know that their productivity is impacted, and therefore it means from a career or career progression that they will miss out on more opportunities than any other woman, right? Who is their counterpart, who is experiencing normal periods, right? But there's also the fact that this is an issue, and it's a condition where no one believes that you're actually going through pain, right? So endometriosis, the symptoms are inside of your body, right? Whereas if I cut myself here, you'll be able to see that there's a slit here, and probably I have like a bandage here. But endometriosis is invisible. So it's a much harder task for me to be believed, and especially by female bosses, right? Who are experiencing normal periods. They'll tell you, what are you talking about? Like, what periods are you going through, right? So just the whole concept of first and foremost, first you're menstruating, then you're going through pain, it becomes difficult for me to be believed. So it becomes difficult for that agenda to be pushed, also because we do not have data in terms of how many women are suffering. I mean, we do have, but we've not put that information together so that we can actually come up with policies that then protect the women and girls.
Elsie has eaten our time, but that's okay.
Yeah.
Dr. Charles,
yes.
Just in 0.3 seconds, just tell us, what do you think of Kenya having a policy that supports women when it comes to menstruation?
It's very important. I think we are making strides in the right direction. We have the menstrual health policy, so we just need to ride on it and actualize endometriosis care in there.
Perfect. Thank you. Lucy?
Well, I think it's all about, first of all, understanding what it is, because like she said, most of them will not understand what it is. So giving you a leave for a pain that you're not seeing is tough. So, but I think, like the doctor said, we are heading there. We are heading there.
And Dr. Paul, as we close?
So I think that there's actually room for us to have such a policy. It would be a very, very large number of steps in the right direction. And I think in order for us to get there, we need to first of all raise awareness. Because if we raise awareness, then people see a need. And when you see a need, then you can justify the investment in policy making to ensure that this is addressed.
Thank you so much, ladies and gentlemen. Indeed, it has been a very insightful conversation. We have learned matters about endometriosis, and I understand that this conversation cannot end here because there's so much to talk about and to touch on. Thank you so much. All right, that was Dr. Paul Kogi, Dr. Charles Muteshi, Elsie Wandera, and Lucy Mweni helping me on this conversation about endometriosis. That brings us to the end of our bulletin tonight. Thank you so much for watching To The Point and for keeping it TV47. Do keep it TV47 and have a wonderful night. My name is Anne Odida. See you next time.